First, I would like to thank the organizers for giving me the opportunity to present our results. My name is Lavon, and I'm the head of the Neuro-Oncology Laboratory at Hadassah University Hospital in Jerusalem, which can be seen here embedded in the beautiful village of En Karem. The topic of my talk is the following question: does quantification of hypoxia-mediated microRNAs in the circulation of patients with high-grade gliomas reflect the anti-angiogenic effect of bevacizumab? The answer to this question might have important clinical applications, which will be discussed in the lecture. So let's begin. Some words about brain tumors. As can be seen here, glioblastomas and astrocytomas comprise like 83% of all. What? No, okay. I will stay here. Sorry. Okay, comprise 83% of all brain tumors. So, and belong to a group of tumors that are called high-grade gliomas. Gliomas are the most common primary brain tumors. It's a general name of tumors arising from the neuroglia, and they are named according to the specific type of cell they most resemble to. If they resemble astrocytes, so they called astrocytoma. If they resemble oligodendrocytes, they call oligodendrocytoma, and also there are mixed tumors that are called oligoastrocytomas. Gliomas are classified according to their appearance under the microscope. As can be noticed from the slide, in adults there are no grade 1 gliomas. This means that all gliomas in adults are malignant, and eventually, in most cases, the patient will die from the tumor. The prognosis is the worst for grade 4 gliomas, with an average survival time of 14.6 months. Overall, only 20% of patients survive behind 3 years. So, therapeutic modalities for glioblastoma include surgical resection, then concomitant treatment with chemotherapy and radiotherapy, followed by adjuvant chemotherapy, and then if the patient does not respond to this treatment, it goes to a second-line therapy like bevacizumab. So, what are the current decision-making procedure when a patient comes to the clinics? So first, after the type and grade of tumor is determined and appropriate treatment is selected, treatment response is evaluated every 2 months by MRI. In responding patient, treatment is continued, and in non-responding patient, treatment is switched to second-line therapy, or the treatment is stopped and palliative care is offered to the patient. So what are the pitfalls in this current decision-making? So let's assume that this is the size of the tumor on the MRI before the treatment, and in the second MRI after 2 months, it seems that the tumor didn't respond to the therapy. There are 2 possibilities: true responding or true progression, or pseudo progression in 20 to 30% of the cases. And in the other end, in the non-responding patient by MRI, there are also two possibilities: true remission or the tumor already acquired drug resistant, which was missed by the delayed MRI. So our aim was to overcome these pitfalls. Our aim was to develop a quantitative strategy for a rapid, sensitive, and non-invasive technique for monitoring brain tumor dynamics and response to therapy. To achieve this goal, we have decided to exploit the fact that following treatment, apoptotic and necrotic cells shed their content, including cell-free DNA and RNA, to the circulation. According to the previous slide, tumor-specific circulating nucleic acid in the plasma serum may serve as tumor biomarkers, and identification of such biomarkers may offer a new technique for monitoring brain tumor dynamics and response to therapy. So in a previous study, we wanted to determine whether nucleic acids that originate from brain tumor could be detected in the circulation. There are specific DNA aberrations, such as MGMT promoter methylation and 10q deletion, that are associated to gliomas. So we have studied whether this DNA tumor aberration could be detected in the serum of patients with gliomas. For that purpose, we extracted DNA from the patient tumor, leukocytes and serum, and studied chromosomic allelic losses. For instance, it can be seen here. Here is a patient with 2 alleles in chromosome 10. The tumor lost 1 allele, and you see the same picture in the serum. Also, in this lower figure, when we tested MGMT promoter methylation, which is specific to the tumor, in the leukocytes of the patient and also in LC individual, it's unmethylated. While, for instance, in this patient, you see that this tumor is methylated, as same in the serum, and also in the other patient, the serum picture it resembles the tumor picture. So to summarize, until now, treatment response is evaluated by clinical parameters and MRI, which is very expensive and encounter numerous problems. Therefore, the identification of quantitative, inexpensive, and objective biomarker for response to therapy remains an important unmet need. We showed that tumor-specific nucleic acid are shed from brain tumor cells to the circulation and could be detected in the serum. So, based on our previous study, which demonstrated that tumor-specific nucleic acid are shed from brain tumor cells to the circulation and could be detected in the serum, the current study aimed to develop a quantitative strategy for monitoring and predicting of brain tumor recurrence and response to therapy. To address this goal, the tumor biomarkers candidate should be stable in the circulation and easily quantified. So we thought that circulating microRNAs might answer our requirements and be used as appropriate candidates. First, the amount of microRNAs could be quantified by several methods, such as real-time RT-PCR, which is very inexpensive, nanostring, next-generation sequencing, etc. And also, the microRNAs that are secreted to the circulation are protected from a catalytic enzyme by proteins or vesicles, such as exosomes. In another study, we have demonstrated that 71 microRNAs are differentially expressed between gliomas and normal cells. So we thought that these 71 or some of these 71 microRNAs are tumor specific, and we wanted to take this microRNA and test them in the serum. So we select a panel of 5 microRNAs that were highly expressed in glioma as compared to normal brain. And first, we evaluated their quantification in the serum of 30 patients with glioma and 10 LC controls, and demonstrated that these microRNAs could be reliably detected in the serum of LC control and patients with malignant gliomas, and that these microRNA are highly expressed or highly quantified in patients with gliomas. Following our observation that the highly expressed microRNAs could be detected in the serum of patients with glioma, we aim to study whether they could serve as biomarker to monitor tumor dynamics. To accomplish that, we drew blood from patients with brain tumor before surgery here, and every 2 to 3 months during the different treatment modalities, and quantify these 5 microRNAs in their serum using real-time RT-PCR. To correlate the microRNAs measurements to the tumor volume, each blood withdrawal was a complement with tumor evaluation by MRI. So, what are the expected results? So, if we treat the patient and the patient responds to the tumor and the tumor volume decline, so we should see more microRNA in the patient's serum, because they shed the dying cells shed their content to the serum. And if the patient does not respond to the treatment and the tumor is growing, so what we expect, or decline the microRNA, or it should stay stable because the cells didn't die. The cells of the tumor didn't die. So, as you see here, in 10 out of the 21 patients that we studied, that we had more than 2 blood withdrawal, that there is a negative correlation between the microRNA, in most of the patients, between the microRNA or the some quantification of the 5 microRNA and the tumor volume. This is in the patient with the standard protocol. And if we take all these 21 patients, what we see, the sum quantification of these 5 microRNAs correlate negatively and significantly to the tumor measurement by MRI as it was expected. So our ability to predict tumor resistance to the standard protocol was 100%, but our ability to predict to tumor response to the standard protocol was only 57%, with the accuracy of 73%. Now, when we carefully looked on the results, 2 mirs, which is negatively correlated to the size of the tumor, and only this, not all the 5 mirs, as to the standard therapy. And in these 10 patients. So what here with bevacizumab, the ability to predict tumor resistant to bevacizumab was 86%, and the ability to predict tumor response to bevacizumab was 80%, and the accuracy was 81%. So, following this result, we propose a model in which treatment with anti-angiogenic therapy reduces tumor vascularization and thus induces hypoxia. The hypoxic signal induces the expression of miR21 and 10B, and paradoxically also VEGF, which in turn promote angiogenesis and pneumoxia. And then these two miRs are upregulated, and this can be reflected here. To test our hypothesis, U87 glioma cells were placed for 24 hours under pneumoxic and hypoxic conditions, and the expression of VEGF if1, which is the hypoxia-induced factor 1b, and if2a were tested. As expected, VEGF were upregulated, as well as if1, 2a, and also these two microRNAs. So to conclude, some quantification of these 5 microRNA in the serum of patients with high-grade gliomas correlate negatively and significantly to tumor measurements by MRI following the standard treatment of care. The expression of miR10 and miR21 was significantly negatively correlated to MRI measurements in patients treated with bevacizumab. This might be associated to the upregulation of these microRNAs in the tumor in response to the hypoxic signal induced by the anti-VEGF therapy. Routinely, measurement of these microRNA in the serum of patients with brain tumors may serve as biomarkers for treatment response. So what are our future plans is to validate this result and see if we can predict the tumor response, if it grew or it responds to therapy. We hope that in the near future, treatment response would be evaluated by a simple blood test. And to summarize my talk, we wanted to address an unmet need and find objective biomarker for treatment response. For that purpose, we longitudinally assess tumor-specific microRNAs in the circulation of patients with gliomas and correlated to tumor measurement by MRI. And we found significant negative correlation between tumor measurements and tumor-specific microRNAs in the circulation. We hope that following validation, this test will be used routinely in the clinic for evaluation of treatment response. So with the picture of Jerusalem in night, I want to end my talk and thank the people who did the work. From our laboratory, Hannah, Anat, Tamar, Bracha, and Professor Lusus, the clinician. From the Department of Neurosurgery, Do and Igal, the statistician, Ariel Benis, our collaborator from Australia, Melbourne Hospital, Lucy, Michael, and Andrew Kay, and Tali Sigal from the Neuro-Oncology Center at Rabin Medical Center. And thank you for listening.
This interesting paper is open for discussion. Yes, question in the back.
Yes, I would like to know if you have the Okay, interesting presentation, thank you. I was wondering why you limited yourself to these 5 microRNAs. You showed initially a study where obviously on an array you studied many more. So by limiting to this few, you actually, or using again microarrays, you could have analyzed at the same time many more markers simultaneously, which could have perhaps given you a broader picture and perhaps even giving you a predictive marker whether a patient may respond or not. I mean, the study you have shown is you can follow the treatment. So when you monitor the treatment, then you can see what's happening. But what I'm kind of hoping for was a marker for a predictive. So where the medical doctor at the outset, actually before deciding what to do, has a marker that can be analyzed. So why did you select only these few markers?
This was only the first step of our study. Now, as you suggested, and that's what we are doing, we collect serum every 2 weeks and not every 2 months, and see if we can predict tumor response. And also we do this microRNA by genome sequencing, so we'll have the whole microRNA. So
I actually suggest not to select any.
No, we don't select anything. We are not selecting. It was only a pilot study, and when we saw that it could be made, so now we don't select them. We just do next generation sequencing on all the microRNAs, and we follow this patient every 2 weeks, and we do MRI, but not every 2 weeks because it's too expensive, but every 2 months. But we collect the blood every 2 weeks, and then we can see if we can, as you said, predict the treatment response to therapy.
Well, I would suggest not to select every 2 months, but before you treat, you select your sample. And then you just see in the end whether someone will respond or not. We
do before treatment and following the treatment, because as you saw with the bevacizumab, there are some microRNAs that are upregulated following the treatment. So it's very important also to see what happened when you start the treatment, not only before treatment.
This is great science. But I think it also illustrates one of the big problems in coming out with biomarkers. If you have a good sample, you can show that there's a statistically significant difference between responders and non-responders. But a good biomarker should be more than just statistically significant. It should separate the two groups well. You mentioned 80%, something like 80% prediction.
80%.
Well, prediction has two components, sensitivity and specificity, and you can optimize the one without compromising the other too much. Have you done an ROC curve for...
The specificity and sensitivity was 8. That's what I said.
They were both 80%?
Yes, 86 and 80 something, and the accuracy was 80%. So we are not yet there because the blood was drawn like every 2 to 3 months, and this patient will die in 1 year. So it should be like more frequently, and we hope that we'll get more positive results.
Hello, I think I really enjoyed your talk, so thank you very much.
Thank you.
I think that there's some evidence that VEGF inhibitors actually normalize the vasculature, which means that you get a response on MRI when actually you're not getting perhaps a true response. What do you do to sort of avoid this affecting your results?
If you take the contrast, you are true, but you can take the flare in MRI and then you actually see the exact size of the tumor, and we had correlation also to the flare, not only to the enhancement, to the contrast. And I think it's somewhat contradiction if it's really normalized. I don't know if it's true or not, but your point is very good. Yes.
Any other questions? If not, please join me in congratulating Dr. Lavon for an excellent presentation.